So I'm now going to extend the discussion to a relatively new concept of the virtual cross-match. And I'll discuss why this concept has evolved and why it's become so popular and the advantages. We know that sensitization is an emerging problem. This is data from both the SRTR database and the ISHLT, showing that the number of sensitized patients continues to increase, such that about a third of the patients now have antibodies, and about a fifth of the patients have antibodies that could potentially cause problems if we define deleterious antibodies with a PRA greater than 10%, as was shown by Dr. Moria to have adverse outcomes. Now, the problem with the sensitized patient, that pre-transplant, it limits the donor pool. This results in a prolonged and often prohibitive time on the waiting list, and there's an increased waitlist mortality. And you can see here that if patients end up with a PRA greater than 20%, the chances of getting transplanted within the first or second year really drop significantly, and your wait time goes up significantly. Now, after transplant, the problem is still there, because antibodies result in increased risk of rejection, graft loss, and development of allograft vasculopathy, as I mentioned before. This is data from Columbia showing that if you have pre-existing donor-specific antibodies, your 12-year survival is significantly lower than if you didn't. This is data from Smith showing increased mortality, and also this is data from Germany showing the development of allograft vasculopathy with donor-specific antibodies. And we recently published an analysis of the UNOS database showing that the more sensitized you are, the higher your time on the waiting list. And if you are waiting longer on the waiting list due to sensitization, you are much more likely to die on the waiting list or get removed from the waiting list, presumably because you no longer are a suitable candidate for heart transplantation. So this is a really significant problem. And in the same analysis, we showed that patients who were sensitized had worse post-transplant survival as well. So what are the strategies for the sensitized heart transplant recipient? Well, we want to assess the risk, and then we want to avoid, and typically this has been done using a prospective CDC cross-match that we heard about this morning, but I'll talk about the virtual cross-match as well. Patients who are very highly sensitized may undergo desensitization. We may use perioperative strategies to suppress antibodies, such as plasmapheresis and IVIG and even complement inhibitors. And then post-transplant, we continue to monitor these patients to see if they require supplemental therapy. Now, we've heard today the differences between membrane-based assays and the solid phase assays. And really, the advantages of the solid phase assays is that you can get specific class 1 and class 2 IgG antibody identification. You can quantify the antibody, which may be a correlate for cytotoxicity in terms of mean fluorescent intensity. And that this test can be done fairly rapidly. And this is the Luminex assay that we heard about. So in a prospective cross-match, the purpose is to avoid donors with an HLA to which the recipient has cytotoxic anti-HLA antibodies, and thereby prevent hyperacute rejection. So we tested the donor serum, the recipient serum against the donor cells, and if it's negative, we can do the transplant. The problem, as we heard from Dr. Balakrishnan, is that there is a significant geographic constraint with this approach. You have to send blood out to centers, and therefore you can only accept organs from those areas. Or if you haven't got blood out there, then you have to try and get either blood back to you or get some way of getting the recipient and donor samples together to get the testing done. And this can really pose a significant impact in terms of how far you can go out for an organ. The other problem is that every time your patient has a change in clinical status that may lead to sensitization, you've got to send more blood out. So if a patient gets a transfusion, or if they get an infection, you may end up having to send blood out again to those remote centers. Well, the virtual cross-match has been increasingly adopted as a way around this geographical constraint. And the principle is that you use the solid phase assay to predict compatibility of donor organs by comparing the potential recipient's HLA-specific antibodies with the HLA type of the prospective donor. So this is called the virtual cross-match. And so the important part here is that you have to know what the HLA type of the prospective donor is. And in this approach, what you do is you determine the antibody of the recipients, and you assess which antibodies are likely to be cytotoxic, either by measuring the MFI value and determining that these MFI values are in the cytotoxic range, or by doing a C1q assay that we heard earlier. And in the US, all we do is that we'll basically enter those unacceptable antigens into the UNOS computer, and we'll let UNOS know that if you have a donor with those antigens, don't call us and don't wake us up middle of the night. We're not interested in that donor. So this approach really does allow us to take immunologically compatible donors without having to do a CDC cross-match or without having to send blood out. Now, how do you determine which antibodies are going to be cytotoxic? Well, we heard that single antigen assays are, one of the problems is that they're not standardized. You can have variance in terms of assay interpretation depending upon batches of beads, or even from center to center, or the commercial source for those beads. So unfortunately, standardization is still a challenge, and that hasn't occurred in the United States. So it really is important that your individual center and immunology lab does its own standardization. And this is something that we've done in the past and published on. And what we do is we determine the MFI which correlates with in vitro cytotoxicity with the CDC assay. And at our center, this occurs between an MFI of 5,000 or 10,000. So we know that if we have an antibody greater than 5,000 or 10,000, we're going to avoid those antibodies because they're much more likely to cause cytotoxicity. We also know that if those MFIs are on the higher side, we're more likely to get a flow positive cross-match, but a CDC negative cross-match. So these will be flow positive, cytotoxic negative antibodies. And that's important to know, because while you can go to transplant with these patients, they are going to be at increased risk of rejection post-transplant. So here's the virtual cross-match. We're going to avoid donors with an HLA for which the recipient has strong anti-HLA antibodies and try and prevent hyperacute rejection. So this is a report that we have, and essentially our threshold is 5,000, so we're going to avoid anything above 5,000. In this case, it's going to be B37, B51, B78, and for class 2, DQ7, DQ9, and DR7. And the advantage of this is that you don't need the donor cells and recipient serum. We can go much further out, and this is much more easy to do, because if the patient gets a transfusion or has a sensitizing event, you just run another single antigen bead assay and see if there are any changes in their antibody profiles. Well, does this approach work? Well, a few years ago, we looked at the impact of the virtual cross-match on waiting times for heart transplantation in our program. And what we found was that the mean waiting time pre-introduction of the virtual cross-match at our center was about 130 days. That drastically dropped to less than 60 days following the adaptation of the virtual cross-match. And we also looked at post-transplant outcomes in these patients, and we saw no signal for rejection. Freedom from rejection was unchanged compared to the pre-virtual cross-match era. And we also saw that 3.5-year survival was also comparable. So this is a safe technique to use. And Joe Stellick at Utah also did a comparative analysis of the virtual cross-match with a prospective CDC cross-match where patients underwent both forms of testing to really assess the performance, relative performance of the test. And what they found was that the positive predictive value for the virtual cross-match was 79%, and the negative predictive value was 92%. And their conclusion was that although the negative predictive value was 92%, that meant that 8% of patients had incompatible cross-matches. The retrospective cross-match that is performed following transplantation allows us to guide post-transplant therapy in these patients. And the fact that the positive predictive value was 79%, which implies a 21% false incompatible rate, which means that you're likely rejecting organs that are probably compatible. However, this is balanced by the fact that you no longer have geographical constraints and you're able to go out much further to get your organ. So I just want to move on to another important concept, which is the calculated panel reactive antibody. The calculated PRA is the percentage of donor hearts in a given population to which a heart transplant candidate has significant anti-HLA antibodies. The higher the calculated PRA, the harder it is to find a suitable donor. So a calculated PRA of 70% basically means that 70% of your donor population will be incompatible and potentially turned away automatically. There are now a number of calculators that are available and adopted by individual countries. UNOS has a CPRA calculator based on antigenic frequencies from over 100,000 kidney donors. Canada has adopted the same approach for their virtual cross-match, and as has Europe. And we had interesting discussions yesterday regarding the possibility of really establishing a calculated PRA for the Indian subcontinent. And this should be possible because all the data is available in the kidney transplant population. And I was looking at the slides from previous presenters showing that there are probably 200,000 kidney transplant donor HLA types in the database. So that should be more than enough to establish a local CPRA calculator. So how does this help us from our perspective? Well, what we do at our program is we check the PRA. If it's greater than 10%, we know that the PRA greater than 10% is associated with adverse outcomes in the literature. So we'll dive further deeper into seeing what types of antibody this patient has. We'll specify the antibody and quantify it using single antigen bead assays. And then we'll enter those numbers into the CPRA calculator on the UNOS website. And if it's greater than 50%, that means that less than half the donor pool is going to be compatible with our patient. That means that our patient is at increased risk of mortality on the waiting list or having complications on the waiting list. So those patients will end up considering desensitization and then listing them for transplant. If the calculated PRA is lower, we'll just go ahead and list them for transplant. If their PRA is less than 10%, we'll routinely check them every 6 months or 2 weeks after a sensitizing event, such as an infusion or a transfusion. And if the patient does undergo desensitization, or we know that the patient has antibodies, then we will do either a prospective or a virtual cross-match. And we'll do a virtual cross-match if the patient has low levels of antibodies and we know that the CPRA is low, and we'll do a prospective cross-match if we know that the patient's highly sensitized, hasn't responded to desensitization, and we really want to know whether these antibodies are going to be cytotoxic, so we'll still do a prospective CDC cross-match for that population. So I want to give you an example of this case that we transplanted earlier this year. 22-year-old female, presented to us in May with cardiogenic shock from peripartum cardiomyopathy. She underwent placement of biventricular temporary support with an auxiliary impeller 5.0 and a tandem RVED. She waited, unfortunately, more than 2 months because she was highly sensitized. She had all these antibodies that you see there. On July 10th, she had a cardiac arrest requiring placement of a VA ECMO circuit, and 2 days later, we moved on to placing a 50 cc total artificial heart. Now, this patient had a number of high-level antibodies. If you can't see from the back, in the red box, you can see all the MFIs greater than 10,000. So we listed all of those as avoids. On August 20th, we did get an organ offered. This organ avoided all those antibodies, but did have a low-level donor-specific antibody that we were crossing at about 2,500 to 3,750 a DR4. But we felt that this was an acceptable virtual cross-match to proceed in this highly sensitized patient. So because she was highly sensitized, we did a CDC cross-match, and the CDC cross-match was negative, but the flow cross-match, as expected, was positive both for the most recent serum sample and historical serum samples for both T and B cells. So we went ahead and transplanted this patient, and she's currently doing very well. So in summary, sensitized patients have prolonged and often prohibitive wait times to transplant. This translates to an increased wait time mortality. The number of sensitized patients awaiting transplant is increasing, at least in our population. The virtual cross-match lifts the geographic constraints to help expand the donor pool and thereby reduce that wait time to transplantation. And using the virtual cross-match, the post-transplant outcomes are comparable to patients undergoing transplantation with a CDC prospective cross-match. Thanks for your attention.